So the comprehensive ophthalmic app and with augmented reality. Can I timer face me? Okay, fine. Can I start, sir? Yeah. So this is a neuro-ophthalmic app that we devised. So there were a lot of theoretical limitations, especially when it comes to neuro-ophthalmology and structures relating to non-dissectable structures like the cavernous sinus, the circle of Willis, or the complex neuroanatomical structures. So keeping that in mind, we wanted to also devise a digital application called the IMG Max, where we use 3D animated ophthalmic images, more of unanimated images. We built a 3D interface with real-time confocal images for learning as well as for e-counseling. So this is subtractive learning, virtual dissection, and augmented reality. So you can see the buttons here given in this app. The user will have the freedom of choice to remove the skin or choose the skull. With the fingers, the dissection can be done, which is not possible or never been done, at least the neuro-ophthalmic complex structures in the curriculum. So the meninges are now being removed, and then you can see the brain stems can be selected, or the brain. So the structures that the user or the pedagogue does not want to really see, or reduce it in transparency to really study where is the anatomical correlation between one structure to the other, which the textbooks does not offer, because of you can't subtract something in a textbook or in a printed format, right? So we just start with the anatomy, get it done in a three-dimensional way, read the Cunningham's Chaurasia and got it in a three-dimensional way done. And you can see this is subtractive learning. Also, you can do the virtual dissection in the eyes also is possible, as well as the different nerves, the cranial nerve pathways, each with each, or you can also have different nerves separately. So this is not only done in a two-dimensional interface or a three-dimensional interface. We went one step ahead in the smartphone, where you can have the LiDAR technology. This is launched today. If you type IMG Max in your App Store, it is there, where you can see this as a hologram appearing in your mobile phone. You can walk out with this Wikipedia or this neuro-ophthalmic gadget in your pocket today. You can see that now with the fingers you can rotate it, you can move through it, navigate it, and this is going to be where the anatomical relationships, which are very difficult to comprehend, this is something that we wanted to crack, so that it helps in learning as well as even for counseling for that matter. This is the template that you can see. Even a simple fundus simulator is possible. You can see here, once the models are loaded, if I'm going to take my phone into the pupil, the phone mimics like a direct ophthalmoscope. These are simple neuro-ophthalmic things that we need to teach a general physician or even a neophyte postgraduate or an undergraduate, or for that matter any medical person. So this is very, very important, because it reduces the learning curve is what we believed in, because there are a lot of theory in which we tend to talk, but can we reduce the learning curve and increase the shift of speed in making, and even the trochlea or the any structure for that matter in 3 dimensions, and even e-counseling. So what we went ahead and did with this was we also validated it as to how practical it really looks, to see the level of satisfaction with the classes for neophytes with this and without this. So the cross-sectional study, a comparative one on a Google platform. The app downloads were done, and the physicians or the first year postgraduates were included, and these were the components of the questionnaire pertaining to knowledge, tutorials, innovative representation, and 217 invitations were sent to the downloads. And we also got 203 respondents who responded about the utility of this particular application that they felt when compared to a textbook. Of course, discrete variables of the satisfaction levels were converted into continuous variables. A pair t-test was done, and the p-value was significant with the 0.05. And it's not that with this app they felt much better. You can see 97.4%, the satisfaction levels were much good. Even with textbooks they were okay, but they definitely felt a 3D dictionary, which is much more subtractive to navigate with the fingers. It was much better is what the feedback that we got, and currently we are working on adding more and more structures. So this serves as a pedagogical transformation, e-counseling stations. Even for ophthalmology, it can really work out for simple injections to complex surgeries, even moving into glaucoma or retina surgery, it can really work out. But I feel the main thing is neuro-ophthalmology, because of the three-dimensional complexity that neuro-ophthalmology brings on the plate. So this is a QR code, my dear friends. You scan this in your iPhone, because you need to have LiDAR technology, and this app can be downloaded today. It uses real high-resolution confocal fundus images. It simplifies the neuro-ophthalmic concept learning for an immersive 3D pedagogy. And scan this and you get this to use it. And this is one of the photoreal, visual and augmented reality cutting edge, where we can use it for neuro-ophthalmic learning. Thank you. Ma'am, this paper was actually presented in MTC and it won, and they wanted me to present it again because there was no best of best session there. To validate it once again, the scientific committee wanted me to present.
Any questions from the judges?
You said you looked at the knowledge in those who used it versus who didn't use it. So what was your conclusion, or what did you arrive at?
Ma'am,
when you looked at the questionnaire form and you converted it into a continuous variable, what was the result of it?
Ma'am, the knowledge part of it, it was mainly the anatomical relationship structures, how each structure was related to another structure. When the textbooks were used, there is only a single particular frame. We used the questionnaire where the frame of choice. There, the frame of choice is what the author wants you to see. But here with this app, since there is a hologram, you can navigate any way you want to, and the frame of choice is given to the user.
Absolutely understandable.
Yes,
the only thing I wanted to know was, because you said there is a questionnaire sent in, but there is a comparison study done. What was the knowledge in those who used it versus?
Ma'am, it was only the frame of choice. The frame was only thing that we put it in. We didn't have a complex one.
She's talking about the questionnaire. So what you have presented is what they were understood.
Yes, sir.
But when you said that you did a study in that 203 people who responded, so what was the study all about? What was the questionnaire and what was the response?
Sir, in the questionnaire, in the questionnaire it was more on comprehension. That is how quickly they were able to understand a concept better, and how applicative it was compared to it was more of a cognitive one on a grade of 1, 2, 3, 4. How quickly they were able to understand the concept of anatomy better, how quickly they were able to understand the concept of the relationships of the structures better.
So basically you asked them a question and it was a subjective answer that we understood or we didn't understand. You didn't test whether they understood, whether they liked it or didn't like it.
Correct, sir. It was a very basic one because we didn't know who were the downloads. We did try to contact them, so we wanted to have it very basic. Yeah. Thank you, sir.
Next, we have
respected chairpersons, ladies and gentlemen. I'll be presenting my free paper on ganglion cell layer and inner plexiform layer thickness in optical coherence tomography, a better biomarker in toxic optic neuropathy. I do not have any financial or commercial interest in any of the materials discussed in this presentation. This is purely an academic one. Well, toxic optic neuropathy is important optic nerve disease causing acute or subacute, progressive, symmetric or painless bilateral visual loss followed by dyschromatopsia with central or sequocentral scotoma. Drug-induced optic neuropathy can be caused by various medications. Optical coherence tomography is an evolving non-invasive imaging of optic nerve to produce cross-sectional images of optic nerve and retinal ganglion cells. Peripapillary retinal nerve fiber scans measure the peripapillary thickness and ganglion cell layer and inner plexiform layer thickness were analyzed in the optic neuropathy. The objective of the study is to know the GCL and IPL in OCT and compared with RNFL OCT in toxic optic neuropathy. This was a retrospective study done in Neuro-Ophthalmology Clinic at Tertiary Institute of Northeast India. Best corrected visual acuity in LogMAR, colored vision test in Ishihara, relative afferent pupillary defect, optic nerve evaluation were done in all cases. Humphrey visual field in 30 days 2 were done to show the defects. Peripapillary retinal nerve fiber layer, GCL and IPL thickness in OCT were carried out in all cases on presentation, first month and third month. 3D segmentation to compute the GCL plus IPL and RNFL thickness were done. Scan were performed in Heidelberg OCT spectralis, ART9 frames, 3D and 768A scans were taken. 9 cases of toxic optic neuropathies were studied, of which 8 were ethambutol induced ATT and 1 case of anti-malaria artesunate which was studied for the optic neuropathy. Now in result, we have compared the on presentation first month and third month for the right eye, and visual acuity in LogMAR was 0.8 plus minus 0.83 on presentation, and it reduced to 0.10 in 1 month unit and in third month 0.40 unit. Humphrey visual field analyzing mean deviation in decibel were minus 14 unit on presentation, minus 4.32 unit in first month, and minus 163 in the third month. GCL again was decreased from 82 to 61.02 in third month, and PRNFL on presentation was 115.31 unit, and it also did not show decrease in first month, and later on in third month it decreased. In left eye also this visual acuity was seen, which was in decreasing trend on presentation first and third month. Humphrey visual field again was decreasing because of the visual problem, and GCL IPL here was in 1 month it was reduced from the presentation, and PRNFL again it did not show decrease in first month. So drug-induced optic neuropathy is important entities that dealt by neuro-ophthalmologists and neurologists. They present with varied manifestation, tuberculosis being the major health problem in India, and anti-tuberculous treatment are being used to treat the disease. Ethambutol and isoniazid can cause vision-threatening optic neuropathy in intensive period of ATT use. The parameters were compared as I have shown on presentation first month and third month. GCL and IPL thickness was reduced in the right eye significantly in presentation first and third month. Also in the left eye same was seen. But for RNFL it was not significant in the first month. Our study was comparable with study by Professor Mark Cooper-Smith, who has taken both 2D and 3D segmentation in the OCT. Limitation of the study was that it was a small size, and to conclude, reduction of GCL layer and IPL layer in OCT were seen in all cases which were more specific than PRNFL OCT change. GCL and IPL are early imaging biomarker in this study for drug-induced toxic optic neuropathy. These are my selected references. I'd like to thank Dr. Kuri, Dr. Das, neurologist Gayatri, and all at SSDN. Thank you very much.
Any questions from the judges? Any comments?
But do you see yourself getting help from this, from the GCs, these markers in prognosticating whether this toxic optic neuropathy is going to improve and this is not going to improve? Have you thought along those lines? How can you get more information, more use out of this information that you're gathering on the GCC and the RNFL? RNFL is increased because of the thickness.
Yeah, thing is that these studies has been seen with acute optic neuropathies as well as chronic optic neuropathies, apart from toxic optic neuropathy. Professor Cooper-Smith, when he saw this first study was done in that vein, and we tried to replicate this study. Now, thing is that provided we have a basic RNFL as well as GCL and IPL measurement in our population, that's very, very significant. Again, one thing is important, that when it presented and the first month of presentation, there was a significant reduction in this entity. But one point is that whether it will be replicable or not, because for wherever the OCTs are there, HR OCT, it is a very costly instrument and may not be replicable for all medical college and other thing. And even GCL and IPL segmentation cost high. It cost around say 3,000 or 4,000 rupees for taking all the scan when the patient are being paid. So reliability wise, that's one point, and but it scientifically it has a important marker.
No, it's a very good study, Didi, but the 2 points what she was trying to say is that can you consider it as an early biomarker? We don't know, is that if you find a particular number would that indicate that this patient is likely to improve, because some of them they improve versus so that I think that's something you should look at. Maybe do a larger study and you will be able to. Did you find you looked at the RNFL as well, right?
Yeah.
So did you find in these patient a particular segment getting more effect, like in NMO you know that there is a nasal effect more than temporal? Do you find something like this?
It is mostly in the horizontal one, that is in toxic optic neuropathy. Yeah.
Thank you.
Thank you very much.
Topic. I'm Dr. Vaibhavi Rao, resident of ophthalmology from St. John's. I'm going to present a topic on B-scan optic nerve sheath diameter, normal cutoff value, and role in diagnosis of papilledema. So the aim for my study was to compare mean B-scan ultrasonographic diameter optic nerve sheath diameter in patients with papilledema and the normal controls to establish normal values. So optic nerve is surrounded by a dural sheath which is continuous with the meninges of the brain. So if there is rise in intracranial pressure, that will be reflected around the optic nerve sheath, and there will be swelling of the optic nerve sheath and there hence increase in diameter. Anteriorly, the optic nerve sheath is distensible, hence intracranial pressure changes is shown in the optic nerve diameter. Maximum changes at 3 mm posterior to the globe. So ultrasonographic ONSD correlates well with the severity of papilledema and is a relative non-invasive technique, helps in diagnosing, follow-up and differentiating between pseudo papilledema and true papilledema cases. So as we can see, due to increased ICP, there is increase in optic nerve sheath diameter and there's perioptic nerve sheath. Optic nerve sheath diameter is measured by ultrasonography, a rapid, easily accessible, non-invasive, and inter-observer variation is quite low, and the measurements are highly reproducible even for novice operator taught in a single training session. Need for my study was to normative value for ONSD is needed as a marker for raised ICP, especially to aid in diagnosis of early papilledema, and the variability in value of ONSD with race, ethnicity validates the study in the Indian population. So various studies have been done in to establish varied ranges of normative value. In Nigerian adult population, the range of ONSD was around 3.6 to 5.1 mm. Another study conducted by Chen H. Included 5.1 healthy Chinese population. The range of ONSD was from 4.7 to 5.4 mm. The materials and methods used were, we had conducted a prospective case control study, and in the period of January 2020 to July 22, and the study population we included were all patients of papilledema with age and gender matched controls. We had included patients diagnosed clinically with papilledema and confirmed cases of raised intracranial pressure, and they are normal age and gender matched controls. We did not include the patients who cannot be shifted to OPD and the uncooperative patients. And we underwent a complete evaluation, and the patients diagnosed to have papilledema were subjected to B-scan ONSD, and similar age and gender matched controls were taken, and we measured B-scan ONSD for them, and we divided the case divided into group 1, that is cases, and group 2, that is controls. So retrobulbar ONSD measured 3 mm behind using B-scan ultrasonography in both patients and control, with probe held horizontally with patients in supine position. So in my case, there was 54.5% of females and 45.5% of males. Cases were 62, contained 62. There were 100 cases, so of 62 females and 38 males, and control included 53 females and 47 males. So causes of papilledema included majority of the cases included increased intracranial hypertension, hence explaining the female preponderance in my study. Other causes included cerebral venous thrombosis, infectious etiology, and other tumors. So 200 eyes in group 1, of that 94 of them had 94 eyes had ONSD of value of 4.1 to 5 mm, and as we can see, the group 1 had ONSD of more than 4 mm. Whereas in group 2, majority of the patients had ONSD value of less than 4 mm. With maximum of the eyes having around 2.1 to 3 mm. And the range of ONSD in group 1 was 4.2 to 5.6 with average of 4.91 mm, and in control group 2 was 2.5 to 3.5 mm with average of 3.02 in controls. So difference in group 1 and group 2 was clinically significant. So our discussion, other studies were conducted by Dung H in Taiwan with the mean ONSD of 4.1 mm. Christiansen had conducted a study which also had ONSD range of 4.8 to 6 mm. Wyman et al. Had conducted a study on 300 patients with normal with ranges of ONSD of 4.94 and 5.17 mm. So the conclusion was B-scan ONSD we recommend as 3.5 mm as a normal cutoff value in our population when clinical papilledema diagnosis is equivocal. And the other conclusions include B-scan ONSD is a reliable, quick, non-invasive tool which can be used to aid in diagnosis of papilledema and can bypass invasive procedure like lumbar puncture, and ONSD is significantly higher in papilledema. Shortcomings of my study was there was indirect tool of measurement of is an indirect tool ONSD to measure intracranial pressure, and there was female preponderance in my case due to higher number of IIH patients. Our study population might not be an exact representation of wide varied Indian population. So my references was Raghunandan et al. And
it's okay. You don't have to read out. And just a suggestion, since you are not part of competition, so you're allowed, but always time yourself. You overshot, and generally, even if your paper is so good, you may not be considered for competition if you overshoot the time. But very nice, very good presentation.
Thank you, sir.
Good evening, everyone. Myself, Dr. Pranay Kumar, and my topic is an OCT-based study of retinal nerve fiber layer changes in migraine. There is no financial interest involved. Migraine refers to a primary headache disorder commonly characterized by severe unilateral throbbing pain and may be associated with nausea, photophobia, phonophobia, and or preceding aura. The prevalence of the disease is somewhere between 2.6% and 21.7%. Women are affected more than men by almost 35%. Coming to the pathology, migraine is a transient phenomenon of cerebral vasoconstriction. The long-standing cases of migraine may lead to retinal structural abnormalities. The chronic migraine causes anomalies in the microcirculation of optic nerve head and may cause retinal hypoperfusion, which finally leads to ganglion cell death in such patients. The aim of our study was to compare the RNFL thickness between the migraine patients and healthy controls and to assess the quadrant which is most affected by migraine. It was an observational case control study in which we included 96 migraine cases and 96 healthy controls. Both male and female who were diagnosed as migraine in the age group of 20 to 60 years were included in the study. Patients with glaucoma, high myopia, diabetic retinopathy, hypertensive retinopathy, retinal vascular occlusive disorders, and any other neuroophthalmic disorders were excluded from the study. A comprehensive ocular examination was done. It included best corrected visual acuity, color vision, Goldman applanation tonometry, slit lamp examination, and fundus examination. And finally, the OCT of the optic nerve head was taken, and the average RNFL thickness and symmetry of both eyes were evaluated in addition to RNFL superior nasal temporal and inferior quadrant thickness. In our study, the mean age group of the cases was 39 plus minus 10.3 years, and that of the control group was 41 plus minus 9.2 years. Out of the 96 migraine patients selected for the study, 65 were female and 31 were males. RNFL thinning among cases and control, the thinning was significantly more in cases. Out of the 96 cases, 62 had RNFL thinning, the average value being 87 plus minus 9.2 microns. On comparing with controls, there was statistically significant difference with p-value less than 0.05. Maximum cases which had RNFL thinning were women. Of the 62 patients which had RNFL thinning, 44 were women and 18 were men. On comparing with controls, there was no statistically significant difference. Maximum cases which had RNFL thinning belonged to the age group of 30 to 40 years. The mean age of the study sample was 39 plus minus 10.3 years. On comparing with controls, there was no statistically significant difference. The maximum number of cases had temporal quadrant thinning, average value being 53 plus minus 10.1. It was followed by nasal quadrant thinning, the average value being 74 plus minus 11.6. On comparing with controls, there was statistically significant difference only in temporal quadrant thickness. Now, this is an OCT showing a temporal quadrant thickness and a similar OCT in a normal patient, healthy patient. Now, this is our data. In the data, the average RNFL thickness showed significant changes, and when we compare the quadrants, the temporal quadrant was significantly thinner. Coming to discussion, the mean age of migraine patients in our study was 39 plus minus 10.3 years. This was fairly consistent with the study of Leslie-Kalman, in which the mean age of migraine was 37.7 plus minus 11.7. In our study, the average RNFL thickness was 87.8 plus minus 9.2, which was significantly thinner when compared to healthy controls. The results of our study corresponded with the results of Ali Reza Khosravi, which showed that the RNFL thickness was significantly thinner in migraine patients when compared to the control group. In our study, the mean temporal quadrant thickness was 63 plus minus 10.1, which was found to be thinner when compared to controls. In a study of Martinez et al. Using OCT, he found that the RNFL was significantly thinner in the temporal region in migraine patients when compared with age-matched healthy subjects. Now, abnormal RNFL thickness has been observed in patients of Alzheimer's disease, so it can be considered as a potential biomarker. As Alzheimer's disease occurs due to singulated cortex atrophy and episodic memory decline in old age, so it can be used as a complementary index of neurocognitive degeneration. Thinning of RNFL is also associated with patients of multiple sclerosis, as we all know that multiple sclerosis is a central nervous system disease with optic neuritis being a manifestation. Now, it can be considered as a biomarker of neuroaxonal damage in such patients. Progressive thinning of RNFL is also observed in patients of Parkinson's disease. Parkinson's disease, in this, the dopaminergic neuronal cells are present in the inner layer of retina and can be considered as a viable biomarker in patients of Parkinson's disease. The sample limitations. The sample size of our study was considerably less after taking into account the prevalence of migraine. The assessment of ONH parameters and RNFL thickness were not based on the severity of the disease. Conclusion. Migraine is a common problem and is the second most common cause of headache, affecting women primarily. There seems to be a strong correlation between average RNFL thickness and migraine, with RNFL in the temporal quadrant being significantly thinner. OCT has revolutionized a new pathway for anticipating neurological disorders such as Alzheimer's and multiple sclerosis. However, can OCT be used as a screening tool for diagnosis neurological disorders? This remains a question. A much more defined study, including parameters such as choroidal thickness, ocular perfusion pressure, will certainly yield better results. My take-home message would be that OCT can be used as a potential diagnostic aid and prognostic tool for certain neurological disorders. OCT, being a non-invasive tool, would be a useful complementary technique to MRI in evaluating longitudinal changes of the neurological disease. It provides the advantage of detecting participants at the prodromal stage of disease and targeting population for cognitive intervention. People diagnosed with neurological disorder can undergo ophthalmic evaluation for a better visual and neurological outcome.
Thank you, Pranay. Nice presentation. But I mean, I was quite surprised to see that temporal quadrant being so thin. I mean, it's like 53 is really abnormal.
So this was based on our OCT machine.
I know, but it's very thin. I mean, it's almost like you. No, I say it's not really nothing to do with you. I'm just saying that it's quite surprising. Did you see any correlation between the duration of the disease and thinness? It's not really severity. There's no way you can classify severity, but maybe with the duration of the disease. Did you have any such sub-study where
followed up, sir? It was not followed up, sir.
No. How long patient had migraine and whether that had an impact on this thinning?
Sorry.
No. All right. Good study. Any other comments?
The kind of migraine with aura, with typical aura, without aura?
Ma'am, in our OPD, patients were sent from the medicine department for refraction or for headache. So I took those patients who were diagnosed as migraine patients by the Department of Medicine. And unfortunately, ma'am, they haven't classified as severe or acute.
Yeah. Thank you. Dr. Shafina.
I'll be presenting on challenges faced in management of optic neuritis in Indian scenario. Optic neuritis is a sight-threatening neuroinflammatory disorder caused by infectious or non-infectious process, and many studies have shown that Indian subcontinent there is a higher incidence of atypical presentation, and the treatment is guided by the result of optic neuritis treatment trial, which is intravenous methylprednisolone followed by oral prednisolone. The aims of my study are to determine the etiology and clinico-radiological profile in Indian patients with optic neuritis and the challenges faced in management of these patients. And the goal was to determine the to assess the cost-effective streamlined treatment protocol for the management of optic neuritis in a developing country like India. And we studied a retrospective study on optic neuritis patients in a neuro-ophthalmology department in a tertiary care center in South India over a period of 18 months. And we included patients above the age of 16 years, and the optic neuritis was diagnosed based on the clinical diagnosis of optic neuritis based on thorough history and clinical evaluation. There's patients with acute onset defective vision with or without pain, relative afferent pupillary defect in unilateral cases, dyschromatopsia and reduced contrast sensitivity, defective field of vision in the form of central scotoma or centrocecal scotoma, normal or edematous optic disc finding, and characteristic MRI findings. And we excluded patients with other retinal diseases and glaucoma that may affect the visual acuity and other causes of optic neuropathy. We also excluded patients with incomplete medical data, follow-up less than 3 months, and who did not complete the treatment. And finally, we selected 197 eyes of 138 patients. Baseline blood investigation was done, followed by neuroimaging. And VEP was done in patients with recurrent optic neuritis, and serum aquaporin for immunoglobulin and MOG immunoglobulin was advised for all patients. And all patients were treated under ONTT protocol. And the patients with antibody positivity was treated with long-term immunosuppressive treatment after neurologist consultation. And in all these patients, we assess the age, gender, presenting visual acuity, contrast sensitivity, color vision, visual field, pupil, fundus, and detailed MRI finding. And the results were the mean age was 38 years and with a female preponderance, and 79 patients were unilateral and the rest were bilateral cases. And among unilateral patients, 48 had disc edema, and in bilateral cases, 25 had disc edema. And coming to the analysis of etiology, out of 138 patients, 2 had diagnosis with tuberculosis, 2 patients with perioptic neuritis, and 1 post-COVID patients with transverse myelitis, 2 patients after COVID vaccination, 9 inflammatory, and 4 were positive with 4 were ANA positive, and 1 patient with sarcoidosis, and 4 lactational optic neuritis, out of which 2 were MOG positive. And among 138 patients, only 68 patients did the serological test, and out of which majority came MOG optic neuritis positive, and 15% NMO positive, 4 were multiple sclerosis, and 21 were double negative. And the thing to be highlighted here is the 70 patients did not do the test because of the financial constraints. However, MRI was done in all 138 patients, and the commonest finding was short segment involvement. And we also compared the patients with MOG positivity, NMO positivity, and multiple sclerosis, and we found that in MOG positive patients, the average age was 34 years, and with female preponderance, and majority of them were bilateral, and after treatment, the visual acuity has improved, and 18 patients with a short segment involvement. And in NMO positive cases, the average age was a little higher, with female preponderance again, and majority of the patients were unilateral. And again, the visual acuity improved after treatment, but it is not as better as a MOG positive patient. And 4 patients had chiasmal involvement. And in multiple sclerosis, the age was a little lesser. And here, again, female preponderance, and all patients had unilateral presentation, and 3 had short segment involvement. And serologically positive patients were referred to neurologists, and they were started with immunosuppressants, and majority of the patients were started on azathioprine. And we referred, neurologist referral was made for more than 70 patients, and only 1/3 followed up. And the treatment compliance was very poor among the treatment patients, and because of the financial constraint, and no plasmapheresis was done again because of the cost. And we also compare our study with other studies done in USA and Japan. And the point to be highlighted that in Indian studies, there is higher incidence of MOG positivity. But in reality, we are treating patients without doing the serological test because the patients are not ready to do the test. And we can see the recurrence rate is higher in Indian scenario. So the main challenges we faced in optic neuritis treatment is the financial constraint, whether it is neuroimaging rate, serological test, or expensive immunosuppressive treatment. And the insurance that cover the neurological investigation and treatment is scarce in India, and also the limited resources and literacy also act as a challenges in treatment of optic neuritis. So how do we cope with this problem is, if there is strong clinical suspicion of MOG or NMOG optic neuritis, that is bilateral cases, recurrent cases, long segment involvement, chiasmal involvement, we insisted the patient to get the serological test done. And also teleophthalmology has a great role in our study, that is, it will help in people in the rural area to access treatment, and consultation fee is also low, and the travel cost can also be avoided. And we can appoint trained nurses who can assess the pupil, the color vision, and central field using Jerem screen. And artificial intelligence also have a greater role, even though the artificial intelligence studies in neuro-ophthalmology is very scarce. And
you can conclude. Your time is up.
Okay.
What's your conclusion? Time is up now.
The last slide.
All right. So the comment. I mean, it's an unusually high number with NMO positivity. I mean, almost 49% having NMO positivity is really unusually high. I know, but not 50%. It's like half of the cases. So I mean, just an observation. Nothing.
Yeah.
As again, it's. And the other comment is that you had, though MOG, you had again a very unusually high patients with MOG positivity, but a short segment involvement only. There was no long segment. So that's again, it's not something which is convention. So it's very unusual. So you might just have to talk to your to consultants and maybe write it up and see whether it is accepted, because these are very unusual findings. Or unusual.
I'll be presenting a topic on clinical spectrum of first episode of optic neuritis in tertiary care hospital in South India. Introduction. Optic neuritis is an inflammatory condition of the optic nerve which is characterized by unilateral subacute vision loss without systemic or neurological symptoms. So female gender around 14 to 45 years is 3 times more predisposed than male. Optic nerve inflammation showed various presentations such as papillitis with edematous optic disc, retrobulbar optic neuritis featuring a normal fundus, neuroretinitis which is characterized by optic disc edema with macular star. So aims and objectives. My aim is to determine the demographic and clinical pattern of optic neuritis in patients presenting to tertiary healthcare hospital, and to study the incidence of multiple sclerosis, treatment outcome and prognosis. Materials and method. Study here is a retrospective analysis where details of ocular examination were retrieved from medical records of ophthalmology and neuromedicine department services for a period of March 2013 to 21, and they were statistically analyzed. So the procedure here was the patients were clinically diagnosed with optic neuritis based on the presenting symptoms, and clinical examination comprising of visual acuity and RAPD, color vision and fundus examination were included. Patients with evidence of hereditary, vascular or toxic metabolic infiltrative or compressive optic neuropathy were excluded in the study. MRI with contrast were performed in all patients to detect the demyelinating disorder. So the statistical analysis used here is SPSS software, and independent t-test was used to detect the correlation between the age and the gender. P-value of less than 0.05 were considered statistically significant. So the results of my study here is 354 patients were records were retrieved, and out of which 151 were males and 203 were females. The average mean age was about 40.25, and the male and female ratio was about 42.5 and 40.2 respectively in male and female. So the results were characterized based on the age as 25, less than 25, 26, and more than 60. So these were my examination findings, where in my study I included the laterality, right and left of the patients, and left were found predominantly high, and visual acuity was considered, and visual acuity at presentation and after therapy was calculated, out of which vision less than 3/60 was comparatively higher side of 170, and color vision was defective in all my patients. Painful eye movement was predominantly present in all my cases, but it was absent in about 144 cases, and painful vision loss was present in about 27 patients. So the RAPD was noted in all my patients, with optic disc blurring was noted in 242 patients. Vision post steroid therapy, there was significant improvement after steroid therapy with vision of 6/9 in majority of the patient, about 177 patients, and MRI lesions was present in 33 patients comparatively. Family history here had a few relevance of which is noted in 13 patients. So this is my MRI imaging of the patient with T2 weighted flare images showing multiple hyperintense lesion predominantly in white matter, callosal and pericallosal region in frontal, parietal and temporal lobes. Other image of MRI T2 flare image showing multiple hyperintense lesion noted specified here, suggesting of periventricular demyelinating plaques which is perpendicular to the body of lateral ventricle and suggestive of Dawson fingers, which is a characteristic feature of multiple sclerosis. So the discussion, optic neuritis is described as a primary inflammation of the optic nerve associated with variety of systemic disorders, acute demyelinating optic neuritis being the most common form. About 15 to 20% of the patients with MS of optic neuritis presented with optic neuritis in initial presentation, and 50% developed optic neuritis during the course. So optic neuritis usually affects healthy young adults between 20 to 45 years of age, female to male ratio of about 3:1. Age of presentation, female predilection were noted in the study was similar to the other studies. In our patients, especially retrobulbar optic neuritis was noted in 157 patients, which is about 44.4%, and neuroretinitis was noted in about 24%, and papillitis disc edema was noted in 31%, which correlates well in accordance to an Indian population. Typical optic neuritis was presented with acute unilateral inflammatory demyelinating condition with characteristic MRI findings. Atypical optic neuritis may be bilateral with systemic involvement. Atypical features include lack of pain, bilaterality, lack of response to treatment, optic nerve head hemorrhages, cotton ball spots, and with relapse upon tapering steroids. About 98.1% had unilateral optic neuritis, which parallels with Indian study. Left eye and right eye was more in compared to other studies. MRI is a valuable predictive tool detecting patients with high risk of multiple sclerosis. A potential use of immunomodulatory therapy requires a multidisciplinary approach collaborating ophthalmology and neurological service. The dramatic improvement was noted as per optic neuritis treatment trial, and MRI revealed demyelinating lesions noted of MS in 33 patients. The risk of developing MS in optic neuritis was noted 3 times higher in women with positive lesion on the baseline MRI compared with those with absent findings on the imaging. So conclusion, the clinical profile of optic neuritis in our patient was in accordance with multiple studies in Asian subcontinent. This study describes exclusively on incidence of laterality which lacks in other major studies. The likelihood of developing acute optic neuritis in patients with multiple sclerosis needs to be considered and dealt prudently. A judicial reference to an ophthalmologist helps in early diagnosis of underlying etiology and effective treatment. Here, these are my references. Thank you.
So you didn't do any serological test for these patients?
Sir, serological, since it was a retrospective study, sir, we couldn't retrieve all the serological data, sir. So we couldn't segregate or rule out with MS very specifically. So
these were the patients in what time frame?
Sir, this was from March 2013 to 21, sir. So it was all in MRD records. And since the patients were referred from neuromedicine services, we couldn't retrieve much data. Only with the MRI findings we could retrieve, sir.
All right.
Since you spoke about laterality, you never had any case which was bilateral, which had bilateral involvement.
Ma'am, yes, ma'am. We had
kept on highlighting the same thing throughout the study.
Since this was a study which was from the records, ma'am, all the studies which we could retrieve were more of unilateral cases, ma'am. But there are few cases with bilateral presentation, ma'am. During the COVID period, there is more of bilateral presentation.
It is not a part of your study.
No, ma'am. This during that time frame, we couldn't come across the bilateral presentation.
Did you make a note of age at presentation? The time of presentation, age of onset to age of, the time before the onset?
Yes, ma'am. These were
all of them recovered, and your main visual category was less than 3/60 was a predominant category of your vision drop pre. And post-treatment, more than 6/9 was what you showed.
Yes,
so, what was the time frame of your onset? Did all of the patients present very early
Acutely?
and it started?
Yes, ma'am. All the patients which we retrieved were all acute presentation. They present with a sudden loss or they're...
No, how long after the onset of the symptom that they presented to you? Did you notice that? Did you take a look at that? That might be an important factor as well.
Okay, sir. I'll take into that.
Thank you.
My name is Dr. Ruhail, and I'm a resident, and I'm going to present on the unique role of an ophthalmologist in diagnosis of stroke. I have no financial disclosures. As we all know, in stroke, every minute counts. The faster it is diagnosed, the better the prognosis. And this requires awareness of all possible symptoms of stroke, and therefore the acronym Be Fast, which includes face, arms, speech, time, and also balance and eyes. The general population fails to recognize the other symptoms of stroke apart from the motor symptoms, and therefore may present in an outpatient department instead of the emergency, and even to an ophthalmologist. And why this study is because as a first-year resident, I witnessed multiple cases of CVA being diagnosed in the OPD throughout my 1-month posting in the Neuro ophthalmology clinic. So I decided to review all these cases, what their symptoms were, what the findings was, and what was the diagnosis. The aim was to document the manifold ways in which a cerebrovascular accident may present to an ophthalmologist. And the methodology, it was a retrospective, simple, descriptive study of all new patients at the Neuro ophthalmology clinic at Arvind Eye Hospital, Coimbatore, during the month of August 2022, which was my posting. The inclusion criteria was all new cases of CVA in that during that period, and those that did not have neuroimaging along with the report to confirm were excluded. So we looked at all new cases during August 2022. There were 710 of them, out of which we looked only for the new cases that were presenting to us, not the known cases, of which we got 14 cases. Only 10 of them had neuroimaging done. So what was analyzed? We analyzed the presenting vision, the symptoms, the findings, as well as the results and neuroimaging. So since 10 cases fulfilled the criteria, 7 of them had presented with field defects, 1 of them with transient obscuration of vision, and 2 of them with diplopia. The transient obscuration of vision patient was a 68-year-old male with no comorbidities. He had a best corrective vision of 6/24 and 6/9, and he had a TOV for 15 minutes duration for 3 days. His ocular examination revealed cataract, but on his complete neurological exam, we found a defective gait as well as an altered mental status. We referred him to the neurologist, and his Doppler scan showed a stenosis of the carotid artery. Symptom 2 is diplopia. We had 2 cases, 54 and 56-year-old diabetic males with 6/6 vision in both eyes. They both had right-sided abduction nystagmus and left adduction restriction, and the MRI scan showed a plaque in the MLF. Symptom 3 was field defects. We had 7 cases. Almost all had 6/6 vision in both eyes, and ocular examination was all normal, apart from the confrontation and the central field defects, which picked up the one-sided field defects. The HFA, this was a HFA, one of the patients, which showed a right-sided homogeneous quadrant tenopia. These are some MRI findings on the patient. This was a chronic infarct in left temporal occipital region, which presented 3 months after onset. This is an acute infarct in right occipital lobe with right P1 posterior cerebral artery occlusion. This was another occipital infarct in the right occipital lobe. Sorry, this is another infarct in the right occipital lobe with a posterior cerebral artery occlusion. So all my cases were between the age group 15 to 70, and 9 of them were males. 3 of them had no comorbidities, and all of them had a presenting vision of 6/6. Most of them had a presenting vision of 6/6, if not for the associated ocular findings of cataract. Only 6 of them complained of headache, And sadly, all of them presented out of the golden period, which is the 1 hour for stroke. The most common presentation was within 3 to 5 days. They were all, ocular examination was all normal apart from the hemianopia on the central fields or an HFA. Occipital lobe was the most common site of lesion, and we had 4 patients with a hemorrhagic transformation, which is potentially life-threatening on the MRI. So coming to discussion, we found more males than females. This because it was small sample size, and this is as opposed to the normal ratio, which is 4:1 of females to males in stroke. There have been many case studies on this, on ocular symptoms preceding neurological symptoms of stroke, but there's no literature on visual fields as visual defects as the only symptoms of CVA in these studies. As a conclusion, as a PG, I've learned that I have to pay attention to the unusual symptoms of stroke like diplopia and transient obscuration of vision. Visual acuity can never predict a CVA. Almost all my patients had 6/6 vision. A normal slit-line examination does not rule out a stroke, and a complete neurological exam is required, including mental status, gait, tone, power. And posterior circulating strokes are most likely to present to an ophthalmologist, and the traditional rule of one-sided hemiparesis may not always be relevant. Thank you. Yes.
Which one? Yeah, absolutely. Yeah, interesting concept. Obviously, I mean, these are known things. I mean, 2 INOs in a month is a good number. I mean, there were a good number of neuro-ophthalmic OPD as well, 700 odd, right, in a month? Good concept.
Good evening, one and all. Today we are going to talk about color vision testing. Is online smartphone app an alternative to traditional Ishihara handbook? The assessment of chromic discrimination ability and the diagnosis of any perceptual deficiency is color vision testing. It's a part of functional assessment of the visual system by ophthalmologists during routine eye examination. With the technological advancements, the digital version of commonly used color vision tests like Ishihara have now become accessible to the general public via online platform. Cone photoreceptors help in color perception. There are 3 types: red, green, and blue. Not all people possess trichromacy. Some are partially colorblind, color deficient, or completely colorblind. The most common form of color deficiency is red-green color deficiency, protanopia, protanomaly, deuteranopia, and deuteranomaly. Acquired color vision deficiencies may be found in cataract and glaucoma. Color vision deficiencies can be caused by ocular diseases, trauma, medication, or aging. The Ishihara test is a color perception test for red-green color deficiencies. It has several test designs formed by introductory plates, transformation plates, vanishing plates, hidden digit plates, diagnostic or classification plates, and tracing pathway plates. With advancements in smartphone technology and medical software applications, physicians are increasingly incorporating in their daily practice. We have smartphone applications or digital versions. It has advantages like its affordable and accessible method, prevents delay in patient care while providers search for an Ishihara booklet, solve the problem of shifting colorimetric values with aging of the physical color plates. It interprets its result by differentiating between color deficient and color normal person. However, it is unable to classify the type like proton or deuton of the color vision deficiencies. In our test, we had 120 randomly selected participants, age of 18 to 30 years, visiting our outpatient department, and informed consent was taken. The tests used were conventional Ishihara handbook and the color blindness test Ishihara plates, that is a smartphone application. The visual acuities are distant and near assessed. Ophthalmoscopy was performed to rule out the presence of any ocular pathology. People with ocular pathology or visual acuities worse than 6/6 corrected were excluded. Participants requiring spectacle or contact lens were suggested to use them. The testing procedure was carried out under standardized condition for both. 2 tests were conducted monocularly in succession, first with the right eye and then with the left eye. The handbook and digital versions were used in randomized order. The criteria for any participant to pass or fail the test for 38 plate Ishihara tests were 9 errors or more, were categorized as red-green color deficiency and failing the tests. In results, we found 52.5% were men, 47.5% were women, and 4 out of 63 men were color deficient, while all women were found to have normal color vision. The sensitivity was the ability to detect all individuals who had red-green color vision defect. Specificity was the ability to detect all the individuals who do not have the defect. The digital version was found to have both 100% sensitivity and specificity as compared to the Ishihara handbook. Various responses from 4 men who failed the screening test on digital version were recorded. The minimum differences were noted on plate 7, 10 to 17, and 22 to 25. Most significant differences were noted between 18 to 21. The digital version successfully differentiated a color vision deficient person from a normal person. However, it was unable to accurately detect the extent of deficiency. It may be because the identical depiction of the slide of handbook was not possible because of the scanned or graphic nature of the digital slides. In our study, we had sensitivity and specificity as 100%. The combined sensitivity of the transformation and vanishing plates of the digital version make it an effective screening tool to detect red-green color deficiency. We have studies comparing the traditional Ishihara handbook with the projected with the computer slides. Gundon and et al. And Gantley said the projector color slides were having good efficiency and sensitivity. Hoffman and Menazzoni had compared traditional Ishihara test to the computer-based screening system, and a spectral emission of the monitor and reflected daylight with the traditional Ishihara plate made some differences, but then also the computer-based method correctly distinguished the subjects with color deficiencies from both those without any. Rodriguez had approximately 20% of the normal trichomates that failed the test. In accordance with Hoffman and Mazzoni, the present study confirmed that the digital method was able to distinguish between participants with and without color deficiencies, and the sensitivity and specificity of the digital smartphone version correlates with the Ishihara handbook. In conclusion, we have that the digital smartphone application is a possible alternative to screening for the color deficiency in unavailability of traditional Ishihara handbook, and also provide a convenient self-screening alternative to in-office assessments, or when test is required to be done by untrained persons in scenario of mass screening. However, test has limitations as it was not able to accurately detect the severity of the deficiency. In case of the participants who are positively identified as having color deficiency, a thorough in-office assessment is required to carry it out by appropriately educated professional using the traditional Ishihara handbook in standardized conditions. Thank you. Yes, ma'am. Yes, ma'am. It was done for reading. Not in this test. We had binocular. Yeah.
Since it's a digital version, I mean, you didn't specify what was the brightness, illumination, and what was the room illumination that you use the phone on, because all that would have a bearing when you're using a digital chart. In what particular phone, what was your screen illumination setting, and did it vary when you did it with different brightness? Because it's a digital version, all those would have a bearing, is my sincere opinion.
It's done with the same brightness for all the patients, but not specified.
You have to get the lux number for everything.
It was around 35 lux.
And
the room illumination.
Room illumination.
Because that will also have been generally when you go to digital for anything, any of these, you would have a standardized illumination to make sure that it works. But a very good concept.
Thank you.
Good afternoon. I'll be speaking on the topic of OCT, the key to dilemmas in disc edema. My name is Dr. Riju Siriak. I'm from Sri Ramachandra Medical College. I'm a junior resident. I just wanted to start off by showing this fundus photo of a patient with evident disc edema, followed by another patient which we saw in the OP with a disc edema. Now, both patients, to clinically alone to diagnose and differentiate these patients would be difficult. So we did a OCT scan for both patients. The first patient, we noticed that the arnophil thickness was substantially high, while the second patient not so. Now, after further investigations, we came to the conclusion that the first patient had papilledema, while the second one was pseudopapilledema. Papilledema is the passive disc swelling associated with raised intracranial pressure, while pseudopapilledema, there won't be any clinical evidence of raised ICP. It can be caused, pseudopapilledema can be caused by optic disc drusen's myelinated nerve fibers. In our study, the aim was to determine the significance of SDOCT as a non-invasive tool in differentiating and diagnosing true papilledema from pseudopapilledema. The methodology, our study design was an analytical cross-sectional case control study. Our sample size was 21 patients with papilledema, 20 patients with pseudopapilledema, and 40 controls. The duration was for 1 year. Inclusion criteria for papilledema patients: all patients with established papilledema with clinical evidence of raised ICP was taken with further investigations. And pseudopapilledema, we took cases of optic disc drusen's, which was confirmed on B scan. Now, all cases in the study groups were subjected to a thorough retinal examination. On fundus examination, OCT scans of patients with disc edema was taken. All the scans were interpreted by a single examiner using spectral domain optical coherence tomography. Each patient underwent an optic disc scan of 200 into 200. The average arnophil thickness and quadrant-wide arnophil thickness was taken in all three groups, and one-way ANOVA was done to look for variability within and between the groups. ROC curve was also done, and p-value of lesser than 0.05 was considered as significant. Now, when we observed the mean arnophil thickness in papilledema, pseudopapilledema, and controls, the mean arnophil thickness in all quadrants was greatest in papilledema, followed by pseudopapilledema and controls. In both papilledema and pseudopapilledema, arnophil thickness was greatest in the superior quadrant and least in the temporal quadrant. And when we looked at the p-value, this is just a tabular column showing all the p-values and all the data, where every mean arnophil thickness had a significant value of lesser than 0.05. The area under the curve for in all quadrants were significant, and all quadrants and average arnophil thickness readings, the maximum value were seen in superior and inferior quadrants in papilledema versus pseudopapilledema groups, indicating its capabilities in differentiating the two. When comparing papilledema and controlled groups, area under curve was greatest for average and superior arnophil thickness. In papilledema versus controls, we observed that the area under curve was greatest for temporal, followed by superior arnophil thickness. Now, in our study, we found that the mean arnophil thickness was highest in all quadrants in papilledema groups when compared to both pseudopapilledema and controls. In some cases, however, we noticed that pseudopapilledema had greater thickness than papilledema in certain quadrants. This could be explained by the fact that the arnophil thickness in pseudopapilledema varies depending on the site of the optic disc drusen. However, this can be avoided by comparing the average arnophil thickness values. In a study done by Bassi et al., very similar variables were taken, where median arnophil thickness and total retinal thickness was taken. The TRT values was useful in diagnosing papilledema and pseudopapilledema from controls in their study. In our study, however, TRT values were not taken. However, it was observed that the average and all quadrant-wise arnophil thickness showed statistically significant results in determining papilledema from pseudopapilledema, and highly significant results in diagnosing papilledema and pseudopapilledema from controls. The conclusion we came to was that SDOCT can be useful in diagnosis of patients with blurred disc margins. It can help in differentiating true papilledema from pseudopapilledema in patients where there are no discernible clinical features, and can be used to raise clinical suspicion for further investigation. The limitation in our study, however, was that the sample size was quite small, so it will be difficult to extrapolate the findings into a larger population. Thank you.
nicely done study, but to make it more impactful, you probably would have to also look at the pattern. I mean, it's just the number would not differentiate between true or pseudo, or to go forward as to what did the OCT picture show. There are various angles which have been described in the literature, and if you look at it, probably will have even more meaningful impact, but very nicely studied and presented.
Sir. Yes, sir. Hello.
Good evening. I'm Dr. Chinmay Mahatme, and I'm here today to share with you our findings regarding macular, microvascular, and structural changes in neuromyelitis optica spectrum disorders and myelin oligodendrocyte glycoprotein antibody disease. I have no financial disclosure or conflicts of interest to declare. So NMOSD and MOGAD are both demyelinating disorders of the central nervous system that have common clinical presentation. It can be tough to differentiate between the two in the OPD, and serology can be expensive, unavailable, and time-consuming. And these two conditions have very different prognostic implications for the patient and have a slightly different treatment approach on the long run. Another way to look at these demyelinating disorders is to study the vascular changes that occur in them. Hypoperfusion and predilection for watershed areas is already well established in multiple sclerosis. In NMOSD as well, vascular mechanisms are hypothesized to play a very important role, especially considering the fact that aquaporin 4 receptors, which are the main target in this disease, are expressed in the perivascular food processes of the astrocytes. However, the chronology of these vascular events is not clear, whether these are causative or secondary to the neurodegeneration. So where can we study these vascular changes? In the retina, of course, because it's the most accessible vasculature of the central nervous system. And how? With the advent of optical coherence tomography angiography, we can study these vascular changes non-invasively, conveniently, and in great detail. So we wanted to study and describe the macular, microvascular, and structural changes in NMOSD and MOGAD using OCTA. And we wanted to evaluate the role of OCTA in the clinical approach towards the evaluation of these disorders. So this was a cross-sectional observational study at a tertiary eye care center in southern India. And the diagnosis of NMOSD or MOGAD was based on serological testing. We had 8 patients of NMOSD, 17 MOGAD patients, and 10 healthy controls. We used the Zeiss Cirrus 6000 Angioplex OCTA system for collecting the OCTA images. And we studied macular vascular density to represent the microvascular changes and the ganglion cell inner plexiform layer thickness to represent the structural changes. Our patients were around 37 to 40 years old in all the 3 groups. Most of the NMOSD patients were female. MOGAD had an equal distribution in terms of gender, and 70% of the controls were female. All of our NMOSD cases were unilateral. MOGAD had an equal distribution in terms of laterality, and this did not apply to the controls. There was an average 3 months duration between the onset of symptoms and the OCTA images acquired in these patients. And NMOSD obviously had a poorer visual acuity at presentation and a poorer visual recovery as well. So coming to the vascular changes observed, when we see the macular vascular density, this graph clearly shows that NMOSD and MOGAD patients, when compared with healthy controls, showed a reduction in macular vascular density even in the unaffected eye. In terms of structural changes, when we compare the GC-IPL thickness, compared to healthy controls, NMOSD and MOGAD patients show a reduction in GC-IPL thickness or a GC-IPL thinning in the affected eye, but not so much in the unaffected eyes. When we carried out t-tests comparing NMOSD and MOGAD to healthy controls, the results that we just saw in the graphs were confirmed. When we compared NMOSD to MOGAD, however, we did not find any significant difference between the macular vascular density or the GC-IPL thickness in either the affected or unaffected eyes. So what do we learn from this? That reduction in macular vascular density is occurring even in the absence of GC-IPL thinning. And this correlates with the findings that have already been observed in multiple sclerosis by Montorio et al. In 2021, where they saw a progressive decrease in macular vascular density even in the absence of thinning. We need more insight into the mechanisms and chronology of these events. Lang et al. Have published a study recently on this very topic comparing NMOSD and MOGAD, and they did actually find a significant difference in GC, IPL, and MVD, which could be used to differentiate between these two diseases. However, as far as our study is concerned, we conclude that OCTA cannot be reliably used to differentiate between these two diseases currently. We did note that in unilateral cases, if the other eye showed both GC, IPL thinning and macular vascular density changes, MOGAD might be more probable. We were not able to identify any subclinical contralateral involvement of the other eye yet. We have only studied the superficial vascular plexus in this study. This was a cross-sectional study design, so it did not allow us to study the chronology of these events that we have observed. And there was a lack of molecular pathophysiological rationale to explain the changes that we have observed. And we still need a larger sample size. So what is next? If we are able to describe the chronology and find the exact pathophysiology of these vascular events in these autoimmune demyelinating disorders, then it might provide very valuable insights into the diagnosis and management of these disorders. If OCTA can play a role in identifying contralateral subclinical involvement of the other eye or seronegative cases, it could be very valuable. These are my references. Thank you. Yes, ma'am. That is a good question. Actually, in our study group, we did not have, we excluded diabetics because of possibility of pre-existing microvascular changes in that, in those patients. But that is something definitely to be considered while evaluating the microvasculature. Yeah. In these patients that we have studied, ma'am, they did not have any other coexisting fundus pathologies. Yeah.
What?
Yes, ma'am.